Good morning, everyone. Welcome to Ocular Pathology Rounds, July 26th. All right. I will go ahead and start with the first case, maybe. If I can get the slide to advance. Okay. There we go. First case. This is a 10-year-old German Shepherd. The history we got was not very verbose. They say hyphema and 3 weeks duration. And secondary glaucoma. So once again, the history we got was hyphema of 3 weeks duration and secondary glaucoma. That is all the information we got. So we hemisected the globe when we got it. So here's the hemisected globe. The cornea is at the top, lens is in the middle, optic nerve is at the bottom. What we have is blood in the anterior chamber. So that's the hyphema that they noted. The lens is present and surrounded by some whitish material. There's also some whitish material lining the ciliary body surface. The retina is detached. And then there's also these clumps of whitish material lining the exposed choroid in these locations. So there are a couple of differentials for this sort of gross appearance. One of which is definitely going to be some sort of infectious disease, with fungal being the a top one. But in fact, that's not what's going on. So here we go. And I'm going to do that. I tried to white balance it earlier and it didn't do a whole lot.
Looks like the auto response or it's set to increased contrast.
And I don't know how to do any of that.
You started a bit simple.
Yeah. All right. Well, we're just going to go with this because that's what we have. All right. Maybe between cases. So the front of the eye, the cornea is relatively normal. Here we are in the cornea. Here is the blood in the anterior chamber that we discussed. There's an iris leaflet. And then moving backward. Oh, I should have done subgross. Oh, well, I'm going to go with it. All right. So here we are on the ciliary body. Here's the ciliary body. Here's the plica. So we have a very densely cellular population on the surface of the ciliary body. And as we move back, you can see the retina is detached. Here is the retina. And then here is that, or that same cell population that's on the surface of the exposed choroid. As we move back, it is lining both sides of the detached retina. And here it's forming a more extensive plaque on the exposed choroid there. And then we move back. Here's the optic nerve. Here's the optic nerve head that's distorted by the detached retina. There's a little bit of hemorrhage in the retina, a little bit of hemorrhage in the kind of vitreal space, I guess. So we have a population of cells that is carpeting surfaces in the eye. So it is very densely cellular, evidenced by how purple it is. So there are two options for this, either inflammatory or reactive or neoplastic. This pattern of cells carpeting surfaces in the eye immediately makes us think about metastatic disease, metastatic neoplasia specifically. So let's go ahead and... And in fact, this one is interesting because it's both inflammatory and neoplastic. Because, oh, it's so dark. It's so annoying. All right, hold on.
Good exposure, say exposure time there.
Yes.
Yeah, just increase that. No, there's a plus. Yeah, either that or there's a plus sign to the right there. Or slide that. Yeah. There you go.
Aspect ratio at the bottom right. You can make it full screen. Okay. There you go.
Oh, nice. Okay, now it'll probably be too bright when we go to a lower mag. But anyway, so what we have here on the surface of the ciliary body is where I went higher mag. We have this population of atypical spindle to polygonal shaped cells. And then adjacent to it, we have a bunch of inflammatory cells and some hemorrhage, so some red blood cells here. The neoplastic cells are spindle to polygonal shaped. They have pretty indistinct cell borders, fairly large nuclei with very prominent single magenta nucleoli. And just in this field alone, we have at least 2 mitotic figures. Here's one and here's one. So this is a repeatable pattern of these cells across the eye. Interestingly, up against the choroid, there is the layer of neoplastic cells that go all the way around this accumulation of viable and degenerate neutrophils. So there's some presumably necrosis occurring in this population of neoplastic cells. Just to look at a few more here. So their morphology is pretty repeatable. In this area, some of them might be caught in a more cross section, so they're looking more round to polygonal than spindle shaped. So those were the main features of this case. There is a pre-iridal fibrovascular membrane, some of which might actually be neoplastic cells in this case. But you can see that membrane on the surface of the iris right here. These might be neoplastic cells here, but that membrane does extend across the anterior lens capsule and the pupillary space. So we have a pupillary membrane that is causing posterior synechia. And over here in the iridocorneal angle, these are definitely neoplastic cells here. And more than likely, they actually had spanned the iridocorneal angle and were causing peripheral anterior synechia. But I think it's a little bit artifactually separated here. There's also a little bit of lymphoplasmacytic inflammatory infiltrate in the iris stroma, which is relatively mild. There is some cataractus degeneration in the lens. So here we have degeneration of the cortical lens fibers and some more ganglion globule formation. So there is a cataract. And then when we look at the posterior aspect of the lens, we have a few lens epithelial cells lining the posterior lens capsule and a little bit more of that liquefaction. So we have posterior migration of the lens epithelium and more cataractus degeneration. So there is a cortical cataract. Retina is detached, as we already mentioned. And those were essentially the features. The glaucoma is a little bit difficult to confirm in this case because of the detached retina, which sort of distorts the appearance of the optic nerve. And then when the retina is detached, a high IOP does not immediately lead to loss of retinal ganglion cells, as far as we know. So there are still ganglion cells remaining in this retina, but there's a pretty darn good reason for glaucoma given what's going on up front. So in this case, we'd call it a presumed secondary chronic glaucoma, or glaucoma as per history. So as I said earlier, this pattern of neoplastic cells carpeting surfaces in the eye is characteristic of a metastatic neoplasm, meaning that this neoplasm originated somewhere else in this dog's body and then arrived in the eye, probably via vasculature, blood vasculature. I did not find any neoplastic cells in any blood vessel lumens in this case, but presumably that is how they arrived in the eye. As far as the variety of neoplasm that we have here, that is a little bit up in the air because these cells are fairly poorly differentiated. I believe personally that this is more consistent with a mesenchymal pattern than epithelial. We've got a bunch of weird mitotic figures in this view right now. But anyway, so this is more consistent with mesenchymal, so a sarcoma of some sort. It could also be a malignant melanoma that is poorly or amelanotic, poorly pigmented or amelanotic. And in fact, that's one of the more frequent metastatic tumors that we see in dog eyes. They didn't give us any additional history. I suggested that we start off with cytokeratin and vimentin just to confirm that it was mesenchymal, because going down the rabbit hole of trying to figure out what kind of mesenchymal neoplasm exactly it gets really expensive really fast. And I wasn't 100% confident that it was a metastatic melanoma to suggest melanoma staining. But it's pretty high on my rule out list for sure. So that's it. They have not chosen to do IHC at this point, and I don't know, maybe this dog has additional history that would have been helpful for us to come up with a more narrowed down differential list, but at the moment I don't know. So let's go
Yeah,
back.
so people here on the chat suggested potentially a hemangiosarcoma. This is a German Shepherd. I think it's all in the table. I was recently looking into some human literature about metastatic tumors of unknown origin in eyes, and you'll be surprised how many there are. There were cases where, well, there was a review, so there were some papers in the literature where up to like 10% of the cases were of unknown origin, meaning they were not able to find a primary mass anywhere else, which is kind of a scary thing. And you know, especially because in human medicine, they have much more risk than we do.
I can't get to the toolbar to fix this. Sorry, folks. The audience, I can't get to the toolbar to fix the display view anymore. Anyway, all right. Now you get the preview. Oh, you're gonna see what the answer is. Dang it.
There you go.
Good enough. All right. Okay, sorry. The people who are in the room don't know what I'm talking about, but there's Zoom and PowerPoint issues happening, and I'm too much of a goober to fix it. All right. Moving on to the next case. Oh yeah, so back to the hemangiosarcoma thing. I would be less worried about that just because of the absolute lack of vascular channel formation. The hemorrhage in this eye, I assume, originated from leaky blood vessels of fibrovascular membranes. But yeah, anyway, who knows?
Agreed.
Okay, so hemangiosarcoma is actually is lower on my list. Of course, it could be a very poorly differentiated one, and then who knows? All right, so moving on. The next case. This is Raymond. Oh, sorry, we're not supposed to say the name. A domestic short-haired cat. Sorry, 6 years old. So the handwriting is actually a little bit hard to read. But on a while ago, they noticed right-sided facial swelling, and it was thought to be a retrobulbar abscess, apparently in 2021, maybe? Fluctuant swelling of caudal mucosa near right sides of the oral commissure, but no pocket. So I'm not sure if that's related to what's happening right now or not. But anyway, then they say in May of 2023, dorsal corneal erosions. And then, oh man, June 5th, dorsotemporal corneal ulcer. And then on the 12th, persistent / firm painful conjunctivitis / chemosis. Dorsal FNA, maybe necrosis with mild neutrophilic inflammation. The cat is also FIV positive. So here is a clinical photo of this cat. So we're looking at the right eye. So here's the third eyelid. This was a piece of paper that they actually submitted to us with the photograph, which is why it has the fold down the center. But this is a perfectly adequate way to give us a picture, and we really appreciate it. So here's the lateral canthus over here, and you can see that there's this bulge of the, oh, my arrow is not showing. Okay, I give up. There's a bulge in the lateral, over the lateral bulbar conjunctiva. So I got the globe, hemisected it, failed to take a nice picture of the globe with the mass attached. And instead, Megan thankfully took a picture of the tissue after the fact. So here's the tissue that I did remove from the globe. And so it is composed, I think there's eyelid skin, haired skin to the right. And then the mass is this composed of coalescing tan nodules. And that's all I'm going to tell you with the gross image. So I will briefly show you the globe with the attached mass at the subgross, as long as we can get that to work. Yay, okay. So here is the globe with attached mass. Oh, good, you can see my arrow now too. So here's the cornea, here's the lens, these are the iris leaflets in cross-section. Here's the optic nerve back here with the retina, it's artifactually detached. And then here's the mass attached to the globe. I had actually cut off most of the mass to section it separately, which is what I will actually end up showing you at high mag. But we have this mass attached to the globe, and it's quite heterogeneous, even at this low magnification. So it's a little bit more densely cellular around the rim, and then the center is a little bit more palely eosinophilic staining. So that is what that looks like at low mag. Here is the piece of tissue that Megan so graciously took a picture of, or another section of that tissue. And actually, this was the orientation, sort of more like this. So here's the haired skin right here. And then here is the mass, which is what I cut off the sclera. So the sclera, it would have been up against the sclera right here. So let's go ahead and go higher mag. So here is the haired skin of the eyelid. Here are some hair follicles. Here's the epidermis. As we follow it around, here's the eyelid margin right here. Here's my Bohmian glands. So here we're getting into the conj here. This is the conjunctival epithelium. We can see that the conjunctival epithelium, as it should, has a nice population. Oh, wait, maybe I'm lying. Goblet cells, hopefully in here. Yeah. So here are goblet cells in that conjunctival epithelium. We have at least one little pocket of inflammation here, composed of epithelioid macrophages and some neutrophils. But let's keep going back for the bigger part of this mass. So let's go back to lower mag. So once again, we actually have rims of inflammatory, inflammation that are more solid, surrounding these pockets of more liquefied material. And so I looked at this and thought, okay, so what is causing this? But anyway, we're going to start right over here. And so these are inflammatory nodules. And in the center of these some of these inflammatory nodules, there are some nematode parasites. So these guys are, the ones that are sampled are fairly degenerate. I think they're not viable anymore, which is probably why there's so much inflammation around them. But if you look really carefully, and I guess I could go higher mag, there are little nubbins poking off the cuticle of this nematode parasite. And there was another one over here. Maybe its nubbins are more. Maybe they're not that much more obvious, but anyway. So I interpreted these as cuticular ridges, and they seem to be running around the girth of the worm. So annular cuticular ridges. The inflammation that we have around them is granulomatous. So we have a bunch of macrophages here, and then right around them are some neutrophils. And then in some areas, if we go higher mag right there, all of these guys with the bright pink cytoplasm are eosinophils. So we have an eosinophilic granulomatous, and then all the smaller nuclei around here are lymphocytes and plasma cells. So an eosinophilic granulomatous and I guess suppurative as well, and lymphoplasmacytic orbital cellulitis that is surrounding nematode parasites. So nematode parasites that are living in this anatomic region with those annular cuticular ridges are most likely going to be Onchocerca. The interesting thing is that this cat came from the Pacific Northwest, which is not an area that should have Onchocerca parasites locally, at least. It typically occurs in dogs, first of all. So this is a cat, don't forget. So this is really kind of a weird case. So this is a cat, and that was pretty unusual in our experience, at least. But it does occur. It is reported to occur in cats. It is transmitted by a biting fly, the name of which I can't remember, which lives in very hyper-local pockets in the Southwest United States. So Utah, that some of them occur in Utah. There are probably some in New Mexico, and I can't remember where else, maybe Southern California.
Southern California.
So, and also other areas of the world, I believe. Greece, yeah. So anyway, this is sort of an interesting lesion, in part mostly because it was a cat. And honestly, when I grossed it, I thought, oh, this is going to be a tumor. So when I put the slide on my scope, I'm like, oh, wait a minute, that's not a tumor. So I asked the clinician in my report if this cat had any kind of travel history. And they came back and said that the cat had actually a medical history from a vet clinic in Utah. So apparently this cat had lived in Utah at some point. Perhaps this cat's FIV positive status has affected its immune system a little bit, and that might explain why it succumbed to Onchocerca. But anyway, I'm not really sure. So an interesting case, and I learned something that cats can get Onchocerca, although I think it's much more rare than dogs. That's all I have for that case. And now it's somebody else's turn. We have a new computer set up at the moment, which is why things are a little bit hinkier than they are normally.
Yeah, it's cool.
New like sources order.
Yeah, okay. So I think it's because I logged into this computer and then my users, I don't know, anyway.
All right, yeah, let's get on. Yeah, go ahead, Megan.
Okay. And I pointed things. No, I don't know if anyone can see pointer.
No, sorry.
Woof. Ah, well. Wait, what? Oh, where?
Keep on right. There it is.
Oh.
Oh, because you have to move it on.
Okay.
They're working as consecutive,
Gotcha.
like
Like a second monitor.
monitors. That's why I was trying to get to display settings there, but this is
Like on a different monitor, virtual monitor.
It'd be nice if we could fix
Yeah,
the
'cause
cell sentence.
It's kind of underneath here. You're right. I want to get underneath there.
Yeah, but then
Oh.
every time you switch back and forth, it goes back to this. Which
Okay.
is annoying. So just-
It'll be all right.
All right. Well, let's see. Hi.
Maybe.
Yep. There you go.
Okay. Okay.
No.
All right. So, there, oh, it is good. Okay, so this is a case that I wanted to pair with one of Gillian's cases from earlier, for a very specific reason. So, you guys kind of get to quiz yourselves on this gross presentation. So this is a 1 year, 5-month-old neutered male miniature schnauzer. Very young dog. They describe a secondary glaucoma in the right eye, which is this eye. But they also describe that both eyes are non-visual with a panuveitis and exudative retinal detachments. It's probably not going to be too significant to our discussion, but the dog is also leptospirosis positive and has been on prednisone and doxycycline. maybe somewhat significant. So here's our gross presentation. And we have these little raised tan white foci lining the inner choroid and kind of on the outer retina as well, which is maybe somewhat reminiscent, although not as visually impressive as, this case back here, if you recall. So, you know, kind of take a minute to quiz yourself on what the top differentials for a gross presentation like this is, while I describe the other findings in this eye. So up here we have the iris that is sort of anteriorly bowed and thin, and the tips are kind of connected to the anterior lens. So this is pretty suggestive of a posterior synechia with iris bombay. We have a retinal detachment, so you can follow the retina here as it's detached, and this just billows of this sort of pinkish red material, which is probably going to be hemorrhage and pus admixed. So that's that. And then I think, yes, okay. And then we're going to go to, yes, all right. We're going to look at the slide. All right. This one. Oh, wrong scope. This one. All right. Like I said, this like we said, the one I put it on has no light source. All right. So here is the globe. Again, we have a look at that iris bombay and posterior synechia, but otherwise the anterior segment is, apart from hemorrhage and synechia, is much quieter than the posterior segment, which has this retinal detachment through here and hemorrhage admixed with some more purpley material. And more purpley material here. So let's look closer at the purple stuff under the retina. And, oh, it kind of looks like the exposure has gone back to, unless, nope, okay, good. It would help if I put the condenser in. All right. So we have the retina, which is detached. We have an outer retinal atrophy. And then beneath the retina, so subretinally, we have inflammatory exudate. And that is mostly composed of these large plump macrophages and some neutrophils. So we have a pyogranulomatous endophthalmitis, which is particularly oriented subretinally. If you've kind of had time to quiz yourself, as Gillian said, probably one of your top differentials for that presentation of multifocal subretinal tan white nodules, rather than metastatic neoplasia, which is a little bit unusual, is a fungal disease. And I believe, let me see, that I gave us a dot, but there we are. Here's a dot. So actually somewhat rare, but definitely there in this subretinal exudate. Indeed, we sometimes see, nope, cancer's in, it's just dark this time. These little organisms here. Yeah, let me see if I can fiddle with it some more.
Then automatic.
Yeah, like it, yeah, I need an automatic setting. Oops. Not breaking slides also.
It's not giving you the option to do that.
It's because I started in simple mode.
Oh,
I see.
Somebody suggested white balance, which you can do, but then it doesn't seem to stick. I don't know.
interesting. So here it is though. Full screen. Oh, right. I should go full screen. Maximize the screen. Technology, am I right? All right. So
Can you focus a little more better?
Let's scroll on the mouse.
oh, a little pixelated, but yeah. I mean, I think it's relatively better. Because it is hard to, I think, with this, with some of our technology stuff to differentiate from other cells. But this is a round cell. It has a very sort of thin, somewhat poorly staining wall, and then a big basophilic nucleus in the middle. And you kind of see these neutrophils clustering around, and then the macrophages clustering around that. So this is a yeast organism at the center of a pyogranuloma. You may have to somewhat trust me on that. It is, I promise. So this is probably the more likely differential for that gross presentation, a fungal endophthalmitis. This is a yeast organism, and there's a couple of dimorphic fungi that can infect the eyes of dogs. Probably the most likely for a case like this is going to be blastomyces dermatitidis. So we did that as a differential, although I did not see any budding pairs, and there were actually very few organisms overall in this eye. We typically, in these cases where we see endophthalmitis like this, expect this to represent an ocular manifestation of systemic disease. And especially that is supported by the patient's other eye having similar clinical findings with the exudative retinal detachments. Another differential for these sort of tannish raised foci subretinally. Probably that would be your top differential fungi. We saw metastatic neoplasia that can cause it, and then probably very, very rare. I would add protistheca to that list as well. It can cause sort of discrete subretinal foci, clinically sometimes described as cotton wool spots beneath the retina. So that's it. There aren't any questions on that. I will move on to the next case.
Presentation.
A little afraid to. What if it changes everything? Okay. Yes. Okay, good. And I still have the pointer. We're good. We're going fine. Here we go. The next case is a 9.9-year-old spayed female domestic short-haired cat. And all they say for the history on this eye is that there's a large rupture with bulbous iris bulging outward. That is our description clinically. And I think it's pretty apt. So this globe is very, very distorted, and mostly because I have the histologic picture for you, I can find my anatomic landmarks, but otherwise it's very, very difficult because it's quite a distorted globe. So over here, we have probably roughly the limbal sclera, and then another side of the limbus over here, roughly. We can see a bit of conj over here to sort of delineate maybe the approximate area of the conjunctival fornix to help us. There's this sort of gelatinous, almost tan tissue that's bulging forward, and at least a clear defect from here to here. So you might think this could be remaining cornea, but I know differently, and we will see on the histologic section. Then we have no evidence of a lens grossly. This is a situation where we'd probably suspect that the lens is somewhere on the living room carpet or perhaps the driveway, i.e. it has probably been expelled through the corneal perforation site. And then we have some sort of translucent tissue back here, which is probably detached and torn retina.
They can't see the arrow, so just.
Oh, they can see the arrow. Dang it. Can you see it now?
Oh, yes, now we can see it.
Yeah.
Interesting. Okay, so we can see it when it's on the other screen and they can see it when it, all right.
So there are three, it's working as three set of screens. So,
Okay. Gap, bulgy translucent tissue, which is not cornea, and we'll see later. No evidence of a lens, detached and torn retina. Hopefully that helps for the folks watching at home. Okay. So that's the gross. Okay, we're gonna switch to the microscope. There we are. That's the last case. All right, let's make it full screen.
You can still do the subgross too if you want.
Still do the subgross. That's right. Probably I do want. But it's very hard to find landmarks on this very distorted case.
So gross works on 2 axes.
Yeah, I have to decrease that exposure too much.
Yeah, now it's too light. Oh, sorry. What just happened? Oh, I could have moved. Oh, you probably need more space back there. All right. Actually, I think, oh. Technology struggles. Is that probably a little bit better?
Should have been. Find a way to automatic here, but
Yeah. Maybe, yeah, just click default. Now it's on automatic.
it's not.
Yeah.
Oh, it's
It's
all
on
right.
automatic. Okay, maybe that'll help.
Now hit F11.
Oh, or F11.
Yeah.
Okay. Okay, maybe we've probably fixed the exposure issues. Sorry for technological struggles. Oh, okay.
Maybe that'll work.
Go back to this really distorted eye of cats. So let me try to orient it a little bit more like it was in the gross image. Like so. And this is that translucent, sort of light brown, almost gelatinous looking tissue that was kind of curling around. Here is that clear gap. There's nothing there in the front of the eye. We also have this suspicious sort of increase in cellularity, and that was represented by some degree of sort of white tan thickening of the tissue at the edges. But we've got these sort of multifocal purplish spots sort of all around. Over here too on this side. And again, that's sort of folded up, detached bits of retina on the back of the eye. So let's take a closer look. All right. Okay. Let's orient ourselves as much as we possibly can. As far back as I can go, I think. Yes, it is. So this is that edge that we saw, and then you follow this tissue that was bulging forward. And again, this was that sort of gelatinous tan looking tissue that was forming that curve. And then we have that gap, right? So this tissue actually turns out to not be cornea, it is iris. And the reason why it looked so tan and gelatinous and translucent on the gross was because it is hugely edematous and congested. So you can barely make out any stromal melanocytes. It's basically just these widely separated blood vessels and this proteinaceous fluid spreading the tissue out. As you get to the edge of the tissue, that's where it becomes more recognizably iris. So we have the tip of an iris leaflet here, and the iris pigmented epithelium a little bit more recognizable on the back. So basically, most of the cornea was just gone in this cat, and it was replaced by this bulging iris, just like they described clinically. But the more interesting thing that I would like to point out is to go back to where we saw that purple stuff at the edges. So a lot of this is inflammation, but as we look on some of the edges of the tissue in particular, so we're at one of the edges where the cornea was absent, basically at the edge of the corneal rupture. And there are these cells that are tracking around the end and kind of going into the globe from there. And then as we walk back here, we have this Descemet's membrane, which is basically detached. There's no recognizable stroma associated with it. And then just solid abnormal cells at this edge here, distorting the peripheral cornea, what's left of it, and the sclera at the limbus. You can kind of maybe guess that the limbus is here based on the distribution of melanocytes. And extending into the ciliary body over here, it's very distorted, but we can see ciliary body plicae and then these abnormal cells in the ciliary body stroma. So these cells are anastomosing lobules of polygonal cells.
Zoom stopped updating.
Zoom stopped updating.
Oh, there we go.
There we go. Okay. Anastomosing lobules of polygonal cells. They have a medium amount of eosinophilic cytoplasm. There's a large number of mitotic figures. Pew, 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 pew. Lots of mitotic figures everywhere. There's a really significant nuclear pleomorphism. And then often at the center of these lobules, we get this anucleate brightly eosinophilic material, which is keratin. Sometimes they form kind of discrete pearls, but basically we've got keratinization in the centers of a lot of these lobules of cells. So this is a carcinoma with squamous differentiation. Basically, squamous cell carcinoma probably arising in the corneal or conjunctival surface, or basically what we refer to as a conjunctival adenocarcinoma in cats with a squamous differentiation. That's kind of splitting hairs. Either way, this is a really malignant carcinoma, which has basically destroyed a lot of the eye, significantly destroyed the cornea, and then moved inside the eye into the uveal stroma. that is this case in a cat. And it's very interesting, I think, just to sort of track its progress and also how it tends to carpet structures. So for example, going back to that hugely edematous and prolapsed iris, you can even make out neoplastic cells on the surface of that sometimes.
Don't get confused with the carpeting that Megan's discussing with metastatic
Right.
pattern of carpeting. This is an epithelial, like an ocular surface pattern of carpeting.
Yes, that is important to point out. This is basically a feature of epithelial neoplasia. It'll grow along surfaces as epithelium kind of seeks to do. So this doesn't tell us it's metastatic. It's most likely, as I said before, arising on the surface of the eye of this cat and then invaded inwards. So that's this case. Okay. There we go. So yeah, the neoplasm was probably what caused the corneal perforation or rupture that they remarked on clinically. This is a neoplasm that could recur locally. This is a neoplasm that could metastasize, typically first to local lymph nodes if it does metastasize. So a case of sort of periocular thick tan tissue, this time that was neoplastic. All right, that's all that I have, and I'm going to give the seat up. No, not next. All right. Great.
All right, so this next case that we have for you is from an 11-year-old neutered retriever mix. This dog was diagnosed with chronic superficial keratitis in both eyes since 2017. It was initially diagnosed in the southern United States. They describe a large, firm, broad-based, red, multilobulated mass arising from the corneal surface and preventing visualization of most of the cornea. It's been unresponsive to neopolydex and Optimmune treatment. So here's our gross image here. On the left is sort of a top-down view of the globe with, as they describe clinically, this large red raised mass blocking the eye. And then on the right here is our hemisection with that red mass, as they said, seems to be confined to the cornea. So I'm going to show that. All right, subgross, pretty similar here. It's our mass, again, coming off the cornea. It's got a lot of hemorrhage and blood in it. And then here's the rest of our cornea that's also looking a little blue. It's a little gap here and such. So we'll take a look at that stuff a little bit closer. It's really close. Okay. It's just a lot closer on the screen than in scope. Okay, so here's ooh, we'll do there. Okay, that'll be good. All right, so we've got conjunctiva coming in here at our limbus, and then here from our cornea, we have this unencapsulated mass that is well demarcated, and it is composed of these neoplastic spindle cells that are forming these blood-filled vascular channels. The spindle cells have indistinct cell borders, a little bit of eosinophilic cytoplasm, the nuclei are kind of plump, oval, finely stippled chromatin, and prominent nucleolus in some areas. There were some mitotic activity. In here, I think there was 4 mitotic figures in 10 high power fields. There are areas kind of here where it gets a little bit more solid. You don't really see the blood-filled vascular channels as much, so giving it a little bit more solid appearance. Mass raises the corneal epithelium, it is ulcerated, so we lose that here. And then the rest of the cornea here, as they described, chronic keratitis. So we have lots of inflammation and blood vessels in the anterior stroma, and we have a lot of macrophages gobbling up pigment, so pigmentary incontinence. And then also we have loss of the epithelium again and ulcerations kind of multifocally through the remaining cornea stroma here. Here's another ulceration. So we have a corneal hemangiosarcoma. The blood vessels and inflammation kind of run into the mass. And so we kind of think that it's neoplastic transformation of the blood vessels coming in from the inflammation. I did take a look at the conjunctiva. It is heavily inflamed. I tried to look for solar changes for like solar elastosis and stuff, because that's a big kind of prefactor for tumor formation. Didn't see any, but again, there's a lot of inflammation here that could be hiding it. So a nice little case of corneal hemangiosarcoma. More neopolidex, yes. All right. There.
The cornea rarely develop any kind of actinic change that I've ever recognized. So solar elastosis is very rare in the cornea, which is perhaps a good thing, because otherwise we would all get it by the end of our lives and not be able to see anything.
All right.
Somebody just said that in the chat. Like, does that happen in the cornea? Okay.
Pre-answering questions. Get the little magic 8 ball. All right. So next up, we have a eye, the left eye, from a 26-year-old red-tail hawk coming to us from Colorado. The findings was an intraocular mass in the left eye of unknown duration. And that's all we have. So here is our hemisections of the globe. Got cornea up front, and then in the center of the eye of the globe, where you might expect the lens to be, there is a white mass that was very hard to cut through, so hard, in fact, that we had to decalcify the globe in order to cut it. Normally, we do have to decalcify avian globes because they do have scleral ossicles that are bony around the eye to help cut it. But this one was a little bit beyond just that. So we have this large white mass in the center of the globe. At the back, there are some defects in the sclera, kind of to the left-hand side. It's a little bit discontinuous. We can see that on the right-hand side as well. Another kind of section, again, mass in the center, some sort of irregularity to the sclera at the back of the globe. And then in this right-sided picture, if you look kind of beyond into the back, there do appear to be some white masses in the back that I also have some sections of to look at. So
Have to assume bird or we have bird.
Good questions. We also don't know if it's alive anymore.
it's, I believe, I'm going to say a rehab
It's not is it better?
based on, yes.
The fact that they knew that it was 26 years old suggests that it's been in captivity for that long.
See, we have bird.
All right. So here is our subgross of our globe. We've got our cornea up top here. Here is our mass. Doesn't quite look as solid as maybe it does grossly. And we'll take a closer look at that. This is the pectin ligament coming off the back of the globe here. It is attached to this mass. And we've got iris and ciliary body also kind of attached in here. So we're going to take a look at all of these things and more. All right. So the first thing I'm going to start with is that there's a little bit of inflammation in the cornea. But we also have breaks in Descemet's membrane here. And what we have kind of attached here is iris stroma. So we have a break with iris stroma plastered there. And as we go back around, we can see here's sort of where the iris base should be, but it's kind of lifted up here with the ciliary body. So we have some cyclodialysis here. There is some fibrosis and sort of just distortion of the angle as it comes up here and is attached to this mass. There is a small fragment right here of lens capsule remaining. And so the lens has actually been replaced by these anastomosing trabeculae of bone that are interspersed with adipose tissue and hematopoietic elements, so bone marrow formation. So we've got a pretty solid mass here, and moving towards the back. Here's that pectin ligament here attached to the back. We follow it down. The retina is very atrophied. It is also detached, but also going in here is we see some recognizable lens. So we've got lens fiber here that are degenerate. We've got bladder cells where the nucleus is maintained. We've got more ganglion globules where we can't see the nucleus and just degenerate lens fiber material. So this is lenticular metaplasia in the retina. Good. Always go towards the blue dots. As we follow the sclera around here, it is a bit discontinuous. And there's fibrotic tissue here. So a chronic fracture at the back of the sclera. And then I'm going to switch over to extra sections of sort of the back of the choroid, posterior eye, and where those white masses were. And so you can see here in like the retina choroid area at the back of the eye, additional masses, and they look exactly like what we saw replacing the lens. With osseous metaplasia with bone marrow formation. So that was pretty interesting. And then just again, some regions where the sclera is fractured. This one looks like it's starting to be more ossified here, with more osteoid looking matrix and osteocytes here in this one. And then I'm gonna go around this way. And so this is the scleral ossicle. This was the normal bone that is found in avian eyes. And it is also discontinuous here. I don't know why I'm trying to use the arrow on the scope. Discontinuous here, and we've got actually prolapse of uveal tissue coming out through the fracture site. I think that was everything involved to show for the eye. So a lot of things going on with this red-tailed hawk eye. So we had that axial break and anterior synechia of the iris there, the lifting up of the iris and ciliary body, the cyclodialysis with fibrosis there, posterior synechia, multifocal osseous metaplasia of the lens, the retina, and the choroid, the synechia of the pectin, the lenticular metaplasia in the retina with retinal detachment and atrophy, and then the multiple fractures in the sclera and the scleral ossicles. So probably some sort of trauma in this bird's life, leading to all of these changes.
Yeah, another common, all those lesions are very classic for chronic, probably blend to ocular trauma. Birds flying at high speed, eye first and things.
Awesome. That's all I have. It's only a
Alright.
couple minutes
That's
to
fine.
go. So
Thanks, everyone.
thank you.
I'll take care of the computer. Okay.
You know,
Just stop sharing then
Yeah,
stop.
you just stop recording. So go to the three dots on the far right. Yep, say stop recording.